all this data is probably very fresh in everyone's mind, and like many of you, I've participated in many of these trials and actively advise many of these companies in the space. This flood of development came about after a meeting with the FDA that took place at the NIH. I remember I was lucky enough to be there with a bunch of other people in this room. And really, this is an expert definition. So to Dr. Bachner's earlier point, we sort of created or defined this disease state to spur development in bladder cancer. And unfortunately, what we did is we created a lot of single-arm trials, which now pose a little bit of a problem as we figure out how to sequence things, but this definition is what led to that. So again, essentially, patients have to receive adequate BCG, which is one induction course, or it could be with a second induction course, or an induction course and a maintenance course. And the patients have to be either BCG-refractory or BCG-relapsing. And essentially, these are patients who have persistent high-grade disease, or those that develop a disease-free state and then recur with disease. And so the FDA has only approved treatments in CIS because they believe that a papillary tumor is being treated by a TUR, and they cannot establish whether a recurrence, whether the absence of a recurrence means you just did a really good TUR or it was your adjuvant treatment. And that's why these drugs were only approved in the BCG unresponsive CIS state. Now, there's a lot of experience with gemcitabine. Again, Dr. O'Donnell's work has found great efficacy in this state, so not just in naive, but in BCG unresponsive. One of the earlier reports from their group showed response rates of about 66% at first surveillance and 34% at 2 years. This is a more recent iteration from the Mass General Brigham group that Dr. O'Donnell is a co-author on, and you can see that the response rates seem to be pretty good. They are better. You can see the difference here between this is high-grade recurrence-free survival for refractory versus relapsing. So, but essentially, it's much better for those patients who are relapsing, but you still see reasonable 60% recurrence-free survival even in the refractory group at a year. So this is a very effective therapy, and I think as we evaluate these newer drugs, we're going to have to reconcile the fact that this is a regimen that's been widely adopted. It is very inexpensive. But I will say that, a lot of private practice groups in our area will not provide this treatment because they have to be attached to a hospital in order to give this. So I would love to know, maybe Mike knows, what the adoption is within the community urologists.
Yeah, we did a survey, and it was only about 10%. Yeah. Many practices have allied with oncology groups, however, to use their infusion suite. That seems to have been a very workable solution for them. We have reduced the dwell time to 1 hour each, and many patients are leaving as soon as the second agent gets in. So it's a little bit less time, but you're right. The single most problem is the loss of opportunity from you seeing more patients in the room where that patient's sitting getting their gemcitabine.
Right.
We're a community group, and we've been doing this now for like 2.5 years. And it was operationally difficult, but once you kind of get going with it, it can be done, and it's very successful.
The follow-up was only 19%, right, at 1 year?
Let me see.
Because if you do the percent of those responses for durability, I think it dropped from 42 to 19%, right? Yeah.
Those are the patients remaining at risk over time.
Those were the ones with CR at 12 months, 19%.
9%. There was a total of 41 patients.
No, but when you look at the That was the 3-month CR, I think, the 42%.
No,
and-
it's actually this is 54% at 1 year, 34% at 2
oh, not
years.
Gemdosi. I was talking about Pembro.
Oh, sorry.
Oh,
No,
Pembro.
I'm sorry.
Previous.
Oh,
Yeah,
Pembro,
let-
sorry.
So here you're
Pembro, sorry.
Pembro was
Right.
19%
That was
and
19%.
11%
Yeah.
at 1 and 2 years.
Sure. Yeah, so,
Just talking with some of the other, but in talking with some of the other large,
so Shilpa's already ahead of us. So I was fortunate to be on the FDA ODAC panel that decided over pembrolizumab. And I can tell you, just when we were discussing whether to prove it or not, the valrubicin data was kind of in the back of our minds. And if you look at the Pembro data, unfortunately, the responses are not that durable. And at 12 months, approximately 20% at most, had a CR. So this is a drug that we acknowledged at the time was not very active. We realized this drug was probably going to be very expensive and come with considerable toxicity. But I think the mood in that ODAC was, we need to improve upon valrubicin. And so, fortunately, this is a drug that's available, but I don't think it's widely prescribed. I've used it 3 times since its approval. So I think it definitely spurred development. And then the next drug that came along was nadofaragene.
Can I make one quick comment in regards to that valrubicin data?
Yeah.
So when you look back at that original publication, and I'm presuming you're referring to the 10% response at 1 year.
Yeah, it was like Steinberg was the first author. I think there were
Yeah.
like 90 centers that had to be
Right.
recruited. Yeah.
But remember, that original trial, the FDA required all recurrences to be considered failure. That 10% includes the low grades, right? When you remove those low grade recurrences and use the same definition of high grade recurrence, that number goes above 20%. It's actually higher than the Pembro data.
Yeah.
It's probably even higher than the Adstiladrin data.
Data out there. It just stayed as an option because there's nothing else out there as a control arm
Well, it's
now.
very similar to the single arm gemcitabine data. It's very similar to the valrubicin data. It's all regressing to that 20% level, which makes you wonder if we're just seeing background activity.
Yeah. Yeah, that's a good point, Bernie. Sometimes I've thought if you just put anything in the bladder, it probably has 20% chance of working at a year. So nadofaragene, of course, this was work. I was a fellow at MD Anderson when Colin Dinney did a lot of this preliminary work, so got to pretty cool to see a drug make it from a concept to actually approval. But essentially, despite its novel mechanism, this is a gene-based therapy that is non-replicating adenovirus that basically leads to continued levels of interferon in the urine. And the response rate, the overall CR rate in the BCG unresponsive group is about 24% at 12 months. It's a very tolerable therapy. And unlike other trials, this did not allow for repeat induction, which you'll see the other trials do. And so the company now is looking at another trial to look at reinduction to see if the response rate can be improved. N803, like many of you, I was a co-author on this study. We treated a couple patients in this with this combination. Specifically, cohort A was the cohort with BCG unresponsive CIS that was treated with BCG. So it's very important to know that these were people who were BCG unresponsive and then retreated with BCG and N803, which is an IL-15 fusion protein. And what's interesting is that the N803 by itself had only a 10% 3-month CR. So it wasn't really, pursued any further. But the cohort A, which was the combination, had a 45% 12-month CR. And again, it also had 55% CR in papillary disease. So this was approved by the FDA. One of the challenges remains is finding enough BCG to give this together. But storage is not an issue. This is a product that's kept in the fridge and then mixed with BCG. TAR 200, so the Sunrise 1 trial basically evaluated this sustained gemcitabine delivery through the pretzel. This is placed by cystoscopic placement, and it's very treatment intensive over the first half of the year. You're treating about every 3 weeks, and then you go back down to every 12 weeks. Essentially, this showed a CR of about 62% at 12 months. Initially, there were some adverse events in the first group of patients enrolled, but subsequent patients, when they made some trial modifications, they saw much fewer adverse events. But essentially, this data was presented at the AUA earlier this year. Credos Imaging reported at the SUO a couple days ago their 12-month CR rate of 46% from this BOND-3 study. This was single-arm BCG unresponsive CIS with or without papillary disease. And essentially, this is an oncolytic virus. So this basically attacks cells that express Coxsackie adenovirus, and it basically replicates and encodes for GM-CSF. And again, low adverse events. This trial did allow for repeat induction. So what's important to know is that 50% of the patients who were re-induced converted to having a CR. So that 12-month CR reflects those patients as well. And this has gotten fast-track designation through the FDA, just like TAR-200 has. I'll just talk about three other agents really quickly and then give you a summary slide. So essentially, EG70 is a nanoparticle formulation. It basically have a RIG-1 agonist and IL-12. This is a product that basically, sits on the shelf and can be administered quite easily. It is noted to produce higher levels of IL-12 in the urine, and they reported their at this meeting at the SUO 6-month CR rate of about 51%. That's from a Kaplan-Meier estimate. I think the actual number is closer to 47%. And they had only 2 patients with grade 3 adverse events, otherwise very well tolerated. And then TARA-2, this is basically a Streptococcus pyogenes that is placed in the bladder and induces a Th1 immune response. In their trial, they looked at both naive and unresponsive patients, and they allowed for repeat induction. And what they showed was a 6-month CR rate of about 72%. But what's important to know is that only 4 patients met the BCG unresponsive definition. So this is too small, I would say, to really get too excited about, but nevertheless something that may end up having a role in the future. And my other iteration didn't make it here, my second iteration of the slides, but there are 2 trials ongoing. One is called Theralase, the other one is the Aura Biosciences trial. They're both photodynamic therapy trials that are ongoing that essentially are looking at a conjugated photosensitizer being treated with near-infrared light. And so those studies are ongoing, and those are other therapies that might sort of be added to this list. But this is not a complete list, but just looking at some of the ones that have reported out, you can see the thing we're going to have to wrestle with is not just CR rates. I think that's important, but the number of urology visits. Some of these products are going to require, patients coming. I have a practice where I have people driving from northern Indiana 3-4 hours to see us. So, giving a therapy like nadofaragene might be easier for them to do, even though it may come at a lower CR rate. So I think the treatment burden for the patients in terms of the amount of visits are going to be important. I think the tolerability is pretty similar across the board, although the numbers may be different. And I think that we're going to have to reconcile how do we not give gemdosi, at least in my practice, at least with nadofaragene and N803 available, we usually exhaust gemdosi after BCG before we put those patients on. So I think this is going to be really interesting how we sequence things, but I'll leave it there and we can go to discussion. Thank you.
One of the interesting things that we're seeing now is more people are looking at and summarizing large data sets of BCG unresponsive patients, is that what we have called BCG unresponsive appears to be something more like BCG less responsive. And so a third course of BCG in some cases is giving disease-free rates that approach what, for instance, N803 is showing.
Right.
Making us a little bit doubt or confused about is BCG unresponsive actually unresponsive. Now, in one case, we in the BCG unresponsive definition, we included T1 high-grade disease that had failed only 6 BCG treatments. At Iowa, we usually retreat those patients, and our disease-free rate at 2 years is 50%. So this may be a major component in that realization is that the reason why it was picked as a unresponsive category was the concern of progression during that time rather than concern about the response rate. So that's one thing. But just so everyone knows that it doesn't mean they don't respond to BCG at all. They just respond less than primary therapy.
Yeah, there's an old paper, actually, Bill Catalona's the author, and it shows a 20% response rate with a third round of induction BCG for people who are refractory to induction. So yeah, there is certainly a response rate to more BCG. And again, this is the problem with this definition that we came up with, that it's not entirely, it's not entirely based in science.
Well, keep in mind, though, that the biology of the tumor hasn't changed. What's changed here is our recognition of who needs to get the bladder out at what time. And so the people that continue to second and third line BCG are highly selected. They're not the patients with symptomatic carcinoma in situ that may be the ones that were included in those early, let's retreat with BCG again. And so T1 disease hasn't changed, CIS hasn't changed. What's changed is the way we're treating and the pool of patients that are now being included here, which is why I think we're seeing these 70% early response rates to a third course of BCG, which not only puts into consideration our definition of BCG unresponsive, but really questions the BCG plus set of agents that are being tested now. How much contribution to these $60,000 a dose drugs is there? And this is why, and we can talk about it now, is how do we move forward here to sort that out?
Yeah, they do have different, Mark Tyson brought this up during his session, which I think is a good point. At least these drugs have different mechanisms. Some of them are quite different. So we might find a world where we can sequence them more intelligently. But we've, on the trials, I'm not sure how many people were treated with gemdosi before they were put on this, because I think most of these patients were BCG unresponsive and then kind of enrolled. But in the real world, at least in my practice with nadofaragene available, which maybe many of you are doing, I'm exhausting gemdosi before I put them on. And so now we're seeing, these were not necessarily the same patients that were treated on the trials.
I'm sure after your gemdosi is given, if there's any evidence of increased number of tumors, increased size of tumors, you probably aren't recommending that they go on to a third course. They're probably having their bladders removed, which means that who's left.
Yeah, these are the patients who, very
One comment and one question. So one pitch for ABLE 41, which is a registry trial or a registry looking at real-world use of Adstiladrin in various centers, that's going to capture some of these questions of post-gemdosi, what the real-world efficacy is and also the patient experience. So that hopefully will give us some more data. My question was, you mentioned cost, and that's not even taking into account the patient visits. But I was a little confused about the number of visits. I was trying to calculate.
Yeah, so that was just sort of like back of the napkin, kind of like having a cysto. So like for nadofaragene, I did 9 visits because having an initial cysto and then coming back for the treatment. So doing that 4 times a year, but the first cysto would be
Got it.
doing, identifying, the tumor, doing the biopsy, and then you do, the subsequent one. So I'm off by a couple of maybe visits, but essentially, I think, depending on, if you don't get reinduced, like for example, in cretostimogene, you could have, fewer visits if you don't get another 6 weeks of treatment. So, but I think, yeah, we're going to have to figure out, how much chair time there is, which is what oncologists refer to their infusions. We need a term for how much, urology,
time?
office time, or stirrup time, or,
Piyush,
catheter
so
time.
I had a question about the pembro one too. You said 17, so that includes the infusion and urology, not just urology.
Right.
Because that's just 4
Yeah,
visits, right?
yeah, like the cysto to show they don't have a recurrence, and then give the treatment. Yeah.
Yeah. I guess, we all say we're going to try to enroll patient trials, but once we have like 5 or 6 agents, some with 75 to 80% CR rates, it's going to be really hard to tell a patient, hey, let's go on a trial because you might get something better. I think, the consideration for the patients are going to always be, let me pick the best choice, and where the best data might be. I think hopefully, we're going to be stuck probably with single-arm trials for a long time. We may be unhappy about the fact that we are basing our decisions based on trials with 100 patients, single-arm with no randomization. The companies are going to be unhappy with the fact that how can you compare one non-randomized trial to another with such small numbers and look at 5% difference in CR and say this is better than the next, and these are legitimate. Then, it's hard for me to say, the preference should be for retrospective data over prospective data or vice versa, purely because of cost. So I think there is going to be, a complicated discussion with the patient. For some patients, cost will be less of an issue. For others, it'll be more of an issue. Obviously, what I would like to see is a better ability to discriminate based on tumor and microenvironment. Does it make sense to give more immune therapy, a second and third line immune therapy, if you could give a chemotherapy or a different mechanism? Even oncolytic virus, is not just immune therapy, it's actually killing cancer cells, right? So I think that's going to be, our struggle, is to try to get better data to try to help select between the therapies. And we are going to be doing a prospective treatment agnostic registry. 15 centers, hopefully will start next year, and that will give us some idea not only of efficacy, but also of quality of life, which I think these are patients who are all trying to keep their bladder, so quality of life is the main reason they're doing it, right? Because the best cure is still to remove the bladder in order to cure cancer in the bladder.
So
That's not invasive.
I do think we're going to be able to accumulate comparative data faster and easier than you think. It's probably not going to be industry sponsored, although it may be. I think there may be a growing appetite for them to help differentiate whether they have the winner or not. But once these drugs are approved and paid for and on formulary, it really isn't going to be that difficult for us then to run institutional or multi-institutional studies where we test gemdosi probably against an agent, a la Stampede. I do think that's exactly what we need to do to be able to sort our way forward here.
And the FDA is going to speak to this. At some point in time, you can't continue to approve drugs in a space where there is less unmet need. And once the community decides what a reasonable control are, it may be physician choice of control, or we could see one of these novel agents or gemcitabine as control. I mean, that's what the community needs to lobby for, because that's the only way you're going to have that kind of comparative.
Yeah.
We are going to have data, but the industry is paying for it. Actually, there's going to be a study that with Beacon, 15-center study to look at BCG unresponsive patients, which, like I said, treatment agnostic. So some patients might get cystectomy, some might get gemdosi, some might go on trial, and some might get approved agents. So that's already being funded by industry, actually.
Steve?
So I think you had the most eloquent point, which is the fact that we're going to end up using these agents, right? We're going to use them in the community setting, and we're going to use them based on trials that are 100 patients. but those patients will be out there and we're going to know the answer. It's just going to take a commitment from physicians, not industry, to collect the data with this. And I think industry, who's listening behind me, would say that it would be best in their interest to fund those things because we're going to do it without them. And then we're just going to figure out in real world settings which agent seems to work the best. Because isn't that what it's all about? It's not about whether or not within their trial of 100 patients what their CR rate was. It's about in the real world which achieves the best CR rate. And so that, like you said, those patients are there. And I think that it will be easier rather than hard if we make a commitment to get that data.
So I completely agree, and that's why, again, a pitch for Able 41 for Adstiladrin and Yair's great idea about, having this real world for all of these agents. And, one trial is being done by John Gore and Angie Smith, but that's restricted, it's called the CISTO trial, CISTO, restricted to patients who go either cystectomy or intravesical. Yeah. So that's very limited in scope of understanding this, but a real-world registry like the one Yair's proposing is probably going to be good. So in terms of randomization, I think those trials are coming, and the cooperative groups were already talking about it and designing those trials where we do have a randomization to a newer agent and what is supposed to be, a relative standard of care. And industry is also interested now in doing more randomized trials. Trying to answer some of these questions.
Bernie, in terms of what happens to these patients as they cascade off from one set of treatments to the next, it's a fundamental observation that CIS does worse than papillary disease. So in the case of gemcitabine, we start out with about 20% CIS patients. When we get BCG failures, we're up to 30 to 40% CIS failures. After that failure, the next group is 50 to 60%. And as you get to third and fourth line therapy, you're seeing 70 to 90% of the patients being CIS. The T1s drop off because they either get treated effectively or they go to cystectomy. And so we create this cadre of patients who have dug their heels in that they're not going to have their bladders removed until or if they have muscle invasive disease. And then you start seeing the progression rates rise and probably some non-salvage occurring. It looks like, based on the retrospective analysis from, about 650 patients here, that the 1 year time frame after being declared BCG unresponsive is very safe. Even 2 years pretty much puts you on the same line as radical cystectomy. It's after that where the window of opportunity seems to begin to close more, and that's where we have to be more vigilant.
Yeah, and maybe just a final word of caution is that these single-arm phase 2 studies are fairly restrictive in the number of T1 patients with CIS that have been included. They're less than a dozen in a single-arm phase 2, and they've gotten wrapped up in the indication labels as well. And so people in the community hopefully are not just seeing that and putting sort of a non-select group of the high-risk T1s on there, but if they're held on to too long, we kind of know exactly where they're headed. So see a final word and we'll move
sorry,
on.
not to have the final word, but unfortunately, I think that is happening in the community. I think patients, still, the practitioners, especially older ones, are dichotomizing between muscle invasive, non-muscle invasive, but T1 deserves its own category, as we talked about. But another word that we need to understand, talking about sequencing, we need to understand the mechanism of resistance to these drugs. They all work completely differently. One's an oncolytic virus, the other one's gene therapy. We need to understand who are the patients who are not responding, and I don't see really a lot of effort or research being done to understand this. So I encourage folks to think about this in the future, so that we can try to sequence these patients in terms of therapy in the future.